every day.
Okay, well, hopefully we'll have some more people joining us. But I think I'll start. What do you think?
Yeah.
Okay. So I want to say hello to everybody here tonight. It's my name's Elizabeth. I think everybody on the call knows who I am, and welcome to Partners for World Health. We're really glad to have our presentations this month on breast cancer to celebrate breast cancer awareness and get the message out there about issues associated with breast cancer. But before I introduce our speaker this evening, I just want to give you a little heads up on some of the events that are coming up here to support the mission at Partners for World Health. And we will have another global health education presentation on Bangladesh in November, date to be determined, but probably the week before Thanksgiving, with a physician from Rhode Island Hospital in Providence, Rhode Island, that was from Bangladesh originally and started an organization called Health and Education for All. And they do a lot of cervical screening in the rural parts of Bangladesh. So that should be an interesting program. We also have some other events coming up. The International Handicraft Artisans Fair is happening on December 4th from 9:30 to 3. And that'll be here. We didn't have it last year because of COVID. So we're pretty excited about being able to offer it again. It'll be enter one way and exit another, and masks will be required regardless of whether or not you've had a vaccination. So we're excited about hosting that again. And here's an example of what will be in the handicraft fair, which is that we have several pieces of pottery along with our baskets. Of course, we have baskets from everywhere, but this pottery came from Peru. And a very nice lady whose husband passed away was a collector of Peruvian artifacts, and she donated all of it to us to put in our handicraft sale. So that should be kind of fun. December 4th, first Saturday in December. Then we have the Thanksgiving 4-miler, which is, if anybody's interested in being a runner, might want to get involved with that. That is happening on Thanksgiving from 9 o'clock here in Portland. And then our big event, there are some other smaller events happening, but our big event is in May 19th of 2022. And that's going to be the Blue Wrap Project Runway, which will be at Merrill Auditorium in the evening. And we're pretty excited about that one too. We have several designers, and we're now raising money for sponsorships and reaching out to numerous businesses. And we'll be selling host tickets and advertisements for our program, as well as having entertainment. And we've already secured Ron Rains, who's a Broadway singer and Man of La Mancha, and also an opera singer. And we're working hard to find 2 other performers so that we can attract at least 1,500 seats in Merrill. Merrill holds 1,900, and I would like to have 1,500 people there because it's a pretty big place. Having been in there recently, never really thought too much about it. But when it's your own production, you really want to fill the entire hall. So we have a bit of a way to go to get there. So that's our big event. We try to hold our global health education series about, we'll say 6 to 8 times a year, not during the summer. And it's open, it's free to anyone. So if you're interested in getting involved in that committee, which helps to organize that, or other events committees that we have, other events that are organized through our events committee, we'd love to have you involved. So I want to introduce to you Suzanne Hoekstra. Suzanne is a colleague of mine and a breast cancer surgeon. She went to undergraduate school at Loyola University in Chicago, and she graduated from Southern Illinois University School of Medicine in 1989 and did her surgical residency at the University of Nebraska Medical Center. She's board certified in general surgery and a fellow in the American College of Surgeons. And she's been practicing since 1998, and she came to Maine in 2010 and started her work at Mercy Hospital here in Portland. And now she's the director of the breast cancer program at Mercy Hospital and works hard at maintaining accreditation in terms of quality initiatives. So we want to welcome her this evening and also to let you know that she's traveled with us several times to Bangladesh and especially at the National Cancer Institute for Research, Cancer and Research Hospital here in Dhaka, Bangladesh, and provided educational opportunities there and surgical intervention also at that hospital and also at some other hospitals, which we did visit a couple of years ago. And we haven't started our medical mission program, but we hope to click that back in 2022. And stay tuned. It's all on the website and we'll be letting people know when we start that up again. So Suzanne, I'll turn it over to you. And would you like me to click the green button so you can share your screen?
I
Right?
think if I click it, I could just share. So thanks for having me. Oh, I guess you have to click it because it said you've disabled screen sharing. So
I share.
you have to give me permission. But now
Hold on just a minute. Oh, I didn't click that.
we should all be experts by now, but we're not yet.
Okay, you should be a go.
Okay, let's try this. Fantastic. Okay.
There we go.
Just get my screen organized here for a second. I can see everything I need to see. Okay, so what I am going to share is breast cancer screening and treatment. As you know, it's Breast Cancer Awareness Month, and breast cancer doesn't know that it's Breast Cancer Awareness Month, but it's a good time for us to make sure that everybody is informed about what their screening options are. And also I thought that I would just talk about an overview of what treatment is like in relation to America. And then Elizabeth also wanted me to share some about Bangladesh and how things were different. So I will do that as well. So just some statistics to start us off. So about 280,000 women in the United States get breast cancer every single year, which is a lot of women. And it is the most common cancer in American women. However, even with those numbers, survival is great, 90% or more, which has been going up through the decades. And that has resulted in millions of breast cancer survivors in the United States. So this is a really good thing. You can see from this chart that breast cancer is about 30% of the cancers in women in America. Behind it is lung cancer and then colon and uterine cancer. So breast cancer gets a lot of the press because it's a big chunk of the pie. In Maine, a lot of people have said to me, oh, we have a high rate of cancer. It's actually not higher than the national average, but statistically, we get about 1,200 cases every year here in Maine. And notably, because we have an older population, about 400 of those, or a third of those, are over the age of 70. So that's a pretty good number of older people with breast cancer.
She froze. Suzanne, it looks like you froze.
A lot of women between 75 and say 85 or 90 that get breast cancer.
We can hear you now. Maybe you
Yeah,
could,
I just got a message that said my internet connection was unstable. Okay, so what did you miss? Did you miss anything?
probably the beginning of that discussion of that slide.
Oh, okay. All right. So just to say that breast cancer keeps going up as you get older until you reach about 75, and then it goes down. But there are an awful lot of breast cancers that occur in the younger ages and even more that occur in the older ages. So if you've heard things like, oh, old women don't need mammograms, that's totally untrue based on this slide. So we need to keep checking our mothers and grandmothers as well. as our sisters and daughters. So I just wanted to talk about screening and what the different options were there. What is screening? Well, screening is where you don't have a problem. You have no signs or symptoms of disease. You're just going in for a checkup done at a regular interval, like going in to get your blood pressure checked or your pap smear or something. So that's what we're really trying to get people to do, is go into screening. Of course, there are diagnostic tests too, and that's where you actually have a problem. So diagnostic mammogram, you feel a lump, you're going in to have that more focused examination done. And even if, say, you had a normal screening mammogram 6 months ago, and now you feel a lump, you could go in and get another mammogram because it's a new problem and it's diagnostic. And that becomes important with insurances and so forth, that it's two different kinds of tests. So there are a number of different types of screening. One is just examination, whether it's self-breast examination or a clinical breast examination by a healthcare provider, and then mammogram, ultrasound, and MRI. And I'm just going to talk about these different types of testing. So what's breast self-exam? Well, Elizabeth, of course, knows this very well, but you should do a visual check in front of your mirror starting at puberty every month, in addition to lying down and examining your breasts with the other hand. And it doesn't really matter if you go in circles up and down, across, as long as you cover all the tissue, and you should really use the flats of your fingers. One thing we don't recommend is squeezing the nipple, which was formerly recommended. But if you're examining yourself and you see a little fluid, that should be noted. But don't try to get fluid out, because actually in many cases it will come out, but it's really when it comes out on its own that we get most concerned. In addition to that, your provider should be doing a breast examination at your annual examination. And I've noticed this is something, as insurance companies change their rules, that gets left off the list a lot, but it's still a good idea to make sure you're getting one by your provider every year when you go in for your physical, because sometimes they can feel something you might have missed on your own exam. So what about mammograms? Well, mammograms are basically an X-ray of the breast. If you've ever had an X-ray, like a chest X-ray looking for pneumonia, or an X-ray of your knee because you thought you injured it, it's the same basic technology, but it's of the breast. And there are usually two views of each breast obtained, one from the side, which would be the left side of pictures, and one from the top, which would be the right side of pictures. And this is a typical normal mammogram. And what we're looking for is things that are white, that show up as masses or lumps, usually are white on a mammogram. Some women say, well, why do you have to squeeze my breast so much? Well, this, I agree, is not the best graphic, but basically this shows you the difference in pictures of where you compress the tissue versus not. The blurred picture is just taken without any compression of the breast. It's all very blurry. You can't really tell anything. And then it's much clearer when you compress the breast. This person has very dense breasts, so it's more difficult to make out things, but definitely you can make anything out in the blurred picture, and you might be able to see something in the clearer picture. And that's why compression is necessary. What about breast density? Well, this is something that is on the mammogram, and the radiologists now across the country are required to put this in their mammogram report. There are different breast densities, and they must say what your breast density is in the report. And if you have significantly increased breast density, then you're required to be told that. And this is important because women with more dense breasts do have an increased risk of breast cancer. It was not always thought to be the case, but now we know that breast density does increase your risk. Also, importantly, breast density does not change after menopause. It may slightly change, but more or less, if you've got dense breasts when you're 20, you're still going to have them when you're 70. And so this is an important factor as well. Here's some examples of breast density. So not dense at all is all the way on the left, and all the way up to extremely dense on the right. And if you have one either heterogeneously dense or extremely dense. Those are what we call dense breasts. And that's where sometimes if you get a letter from the radiology department, it may say, by the way, you have dense breasts and supplemental imaging may be recommended, or you should talk to your doctor about this, etc. Well, it turns out those two categories are half the population. So it's a pretty significant number of women that will get that letter. And so it's doesn't necessarily mean you should be concerned or panicked or alarmed, but it is fairly common. And what they're saying is your mammogram is harder to read. You have dense breasts. You should know that because there's a slightly increased risk of breast cancer. And this is important information. So this kind of gives you an idea of how the different mammograms might look depending on where you fall. So now we have 3D mammography. 2D mammograms have been the standard for many years, but we're rapidly getting to where 3D mammograms are the standard. So what's the difference? Well, in a 2D mammogram, like I showed you in the picture, they squeeze the breast and then they just take one picture from the top and one from the side. But in the 3D mammogram, there's actually a gantry that goes over the breast in each of those two positions and takes multiple pictures over an arc so that you get 1 millimeter slices of each breast. So you might have 70 to 90 pictures of each breast in each dimension. So that's hundreds of images put together. And then the computer can recreate those in 3 dimensions so you can see inside the breast. And if you look at these two pictures of this one rose in a 2D and a 3D image, it kind of gives you an idea of how in the 3D mammogram you can get between the layers and see with more clarity what's happening. And this is actually valuable not only just in women with dense breasts, but women with not dense breasts, because it finds more cancer in every woman, regardless of their breast density, but especially important women with dense breasts. And so at Mercy Hospital, everybody that gets a mammogram now gets a 3D mammogram, but at some hospitals, they either don't have the technology yet, or they're still dividing up some women for 2D and some women for 3D. So it's an important question to ask, maybe if you're getting your mammogram, which one am I getting? Because I think all of us should like to get the 3D, and most insurances are now covering the 3D. And so, you know, that would be the preferred test for these reasons. These pictures are designed to show you that in the 2D image on the left, you can't make out the cancer very well, but in the 3D image where the big arrow is, there is a little cancer there. Now, we're not radiologists, and even though I look at mammograms all day as well, it is harder for me to see this cancer. But trust me, if you were a radiologist, you would have no trouble seeing that the one on the left showed something, whereas, or the one on the right showed something, whereas the one on the left was harder to tell what was going on. So that's the value of 3D imaging. Another thing that can be seen on the mammogram and actually doesn't require the 3D imaging are calcifications. Some of you may have been told, oh, you have calcifications. Well, this is just one idea of what they look like. All these little bright white speckles on the mammogram. Now, the body calcifies its tissues in various areas of the body, for example, arthritis, coronary arteries, etc. But also in the breast, calcium deposits can occur. And sometimes they can occur just because somebody's getting older and they get calcium deposits. But also sometimes it can be related to breast cancer. So if a woman started to have a cluster of calcium deposits like this on their mammogram, that might be cause for a biopsy recommendation. So that's what calcium deposits may look like. And that just gives you kind of an idea of what the radiologist is looking for. So some people worry about radiation with mammograms, and this is meant to be reassuring data here. The radiation dose from one mammogram is equal to one cross-country flight. Well, none of us really think twice, except for now during COVID, but before COVID, about hopping on a plane and flying to Los Angeles. But now, you know, people say, well, I'm worried about radiation from a mammogram. And really, it's the same thing. And so I would just say encouragingly, if you'd be willing to get on a plane once COVID is over, then you should be willing to get a mammogram. You could also say this, that the dose of radiation used for a screening mammogram is about the same amount you would get from your natural surroundings in 7 weeks. So 7 times a year, basically it's like you got a mammogram. Of course, we're only doing 1 a year. This is background radiation. So just being alive, you're getting this much radiation many times over every year. And so again, just to be encouraging about the amount of radiation from a mammogram is very, very low when put in context. And we know that mammography is very helpful. It results in a reduction in breast cancer mortality, or you could say an improvement in survival from breast cancer of about 20%. So getting mammograms helps radiologists find breast cancers when they're very small, which not only improves survival, but also can reduce the amount of treatment. For example, maybe somebody now has a very small cancer that doesn't need chemotherapy, whereas if we waited until it was large enough to be felt, maybe now they would need chemotherapy. So these are also important reasons to get a mammogram. So switching over to other types of screening tests, ultrasound. So what's ultrasound? Well, those are sound waves, or some people would say sonogram, pass through the breast tissue, and you get images of what's underneath the surface. The thing about ultrasound is it often is used more for a diagnostic purpose. When I was talking about the difference between screening and diagnostic, like when there's a focused area that needs to be looked at, like a lump or a new change on a mammogram. But it can be used for screening for all of both breasts. It doesn't have radiation. But the biggest barrier we've had is 2 things. One is it's not always reproducible, and 2 is insurance often doesn't pay for it. So they don't see it as a screening test. They see it as a diagnostic test. And diagnostic tests usually are not covered 100% by the insurance. They're subject to out-of-pocket costs. And so this becomes an issue. And also, even if somebody would have an ultrasound as a screening test, it's still not a substitute for a mammogram. So it's designed to be in addition to a mammogram. Say if somebody had really dense breasts and they just wanted to make sure nothing was being missed, they could add an ultrasound to their mammogram, but they would not be replacing the mammogram with the ultrasound. And this is what some of the ultrasound equipment looks like. The one on the left is one of those kind of whole breast automated units. And the other one is just the small handheld device. The whole breast automated units are nice, but it normally does come down to cost, where they're not well reimbursed. You know, if a center is going to purchase this equipment and then not get paid for using it, you won't actually see a lot of these around the country, but some places do have them. I don't think there are any in the state of Maine that I know of. And these are some of the things you might see on ultrasound. The one on the left is just a cyst, and cysts we don't really worry about, but you wouldn't know it was a cyst until you did an ultrasound. And the other 2 pictures, the top one is probably a benign lump, and the bottom one may be cancerous because it has those jagged, irregular edges. So somebody with a lump or a problem on their mammogram might have an ultrasound that shows one of these things. But again, just to do all of both breasts without some guidance from mammogram or exam, sometimes these things aren't as easy to see as they look like they are in the picture. Another test we use for screening is MRI. And I would say we use this much more than ultrasound as a screening test. Again, ultrasound we use more diagnostically. What is MRI? Well, it's magnetic images of each breast, uses magnetic energy, and it does give 3D pictures. Having a breast MRI, you have to have an IV started because they use a contrast agent called gadolinium. This is different than what you might get for a CAT scan. So if somebody says, I'm allergic to CAT scan dye, this is a different dye. So most people don't have any trouble with it. The nice thing about MRI is it can help distinguish between benign and malignant lesions. Doesn't necessarily mean you wouldn't need a biopsy, but it can give you a clue one way or the other. And most often when we order an MRI, it's women at high risk for breast cancer due to personal or family history factors where they have elevated lifetime risk of breast cancer. MRI, importantly, doesn't give off any radiation. So again, a different test than the other ones. And once again, just to say, MRI is still not a substitute for the mammogram. It's its own separate category of tests. We often do it in conjunction with the mammogram, but not instead of. And this is what the MRI machine is sort of like. Women lie face down and the breasts sort of hang away from the body. So there's no compression like there is in a mammogram. And then you go in the big tube. And these are some MRI pictures, and you can see a bright white spot over on the right. And that would be a cancer in these breasts. But the dye that goes through the breasts really helps pick up things that are brighter or not as bright over time. And then the radiologist can help tell if those are concerning or not. So just to kind of recap those things I was mentioning. So exams, self-exam monthly from puberty onward, clinical examination by primary care provider annually from puberty onward, and mammogram, we recommend annually from age 40 until life expectancy is less than 5 years, which could be a long, long time. I know a lot of people in their 80s that are definitely going to live more than 5 years. So it's recommended to keep getting it. There's definitely no stopping age. If you remember that graph I showed at the beginning, people get breast cancer young, they get it as they get older and older and older, and eventually it drops off. And this is just a chart kind of recapping what the guidelines are that we use. So if you're average risk, and your lifetime risk of breast cancer can be calculated, but average risk people have about a 12% lifetime risk of breast cancer. So that's just the average woman, no family history, et cetera, just gets a mammogram every year from age 40. Now you'll see here the breast density of C and D, those are those more dense breast people. It says consider ultrasound or MRI, and that can be considered. The biggest challenge there is coverage payment, and it can get expensive. So not that we always want to compromise on our health because of cost, but if you're having a couple of $1,000 test every year, it can definitely add up if your insurance doesn't cover it. If you're high risk, so there are a couple of high risk categories, you can calculate your lifetime risk, as I was saying, and we use something called the Tyrer-Cuzick model, and it includes a lot of factors like menstrual history, menopausal history, childbirth history, family history, even breast density. And if your calculation is greater than 20% lifetime risk, then you should start adding MRIs to your mammograms as young as 35. If you're high risk due to something like a genetic mutation, say a BRCA mutation or mantle radiation, which is given for lymphoma at a young age, or some other factors, then same thing, MRI would be added at an even younger age to the mammogram. And one newer category we're using this for is if anybody's had a history of breast cancer diagnosed under the age of 50, then we're also doing MRIs for them once a year, again, in addition to their mammogram, not replacing the mammogram. And if any of these tests that are screening are abnormal, that may lead to diagnostic testing or a biopsy. And usually now we don't do surgical biopsies. If we can help it, we'll try to do a needle biopsy. And you can do a needle biopsy using a special needle that takes a little piece of tissue out of the area of concern, using the mammogram, using the ultrasound, using the MRI machine. So this is what we prefer to do if we can. So what if you have a screening test or diagnostic test and then you're diagnosed with breast cancer? Now what? Well, there are three basic treatment options: surgery, radiation, and medication. But these are kind of intertwining and overlapping. I have a diagram like this that I'll go over with patients who are newly diagnosed and try to walk them through what they have for their type of cancer and what the different treatment options are. Should they have surgery first? Should they consider treatment before surgery? What about a lumpectomy or a mastectomy? Do they need radiation? What about other treatments like hormone therapy, chemotherapy, Herceptin, or any other immunotherapy? And how does that all work together? So I like to use this diagram and kind of write on it and walk them through the process, because it's very complex. Even though we know a lot about breast cancer, everybody's case is very individual. So the first thing in most cases is going to be surgery. So remove the tumor is one goal. So that could be a lumpectomy, which can be done on its own. It could be done with a breast reduction. They usually need to have radiation after lumpectomy, again, depending on individual patient factors. And mammocyte is a partial breast radiation that we sometimes use as well. Alternative to that, mastectomy could be done. That could be done on its own or with reconstruction, even saving the nipple. Some women doing that choose to do both sides for symmetry, but either of these operations, the lumpectomy or the mastectomy, are ways to remove the tumor. The other thing we usually do is check the lymph nodes under the arm. Usually this is for invasive cancers, and it's with a technique called the sentinel node biopsy. So this removes only a couple of lymph nodes in the whole network of lymph nodes under the arm, which hopefully avoids removing normal nodes and reducing the chance of lymphedema. But we occasionally do something called an axillary dissection where more lymph nodes are removed. So nowadays in lumpectomies, we try to do what we call a hidden scar technique, trying to do the scar in places that will be less visible. When I first started in practice, we would just put a scar up front and center. Didn't really matter. And now we really try to be much more cosmetically pleasing about it, if at all possible. Now, after you've had surgery, if you've had a lumpectomy in particular, but sometimes after a mastectomy, you may be recommended to have radiation. So this can be of the whole breast or of just part of the breast, most commonly the whole breast. And radiation is given once a day, Monday through Friday, for about 4 weeks typically. And it's short visits every day, like 15 minutes. So many women are able to just go before work, after work, things like that. Some women that have had a mastectomy still need radiation, and then that's given also once a day, Monday through Friday, but usually about 6 weeks. And sometimes there's also radiation to the lymph node areas too, if somebody has high-risk lymph node disease. So that's a whole second subset of treatment, is the radiation. And this is a picture of what a radiation machine might look like. It's got this large gantry that rotates around the patient. They'll use lasers to line up the beam, and there's been a planning that has occurred where the physicist figures out exactly how much radiation, where to dose it, and so forth. And then they basically zap you through a machine like this. Sometimes they do it also lying on the stomach. It just depends on the planning and the individual patient. So what about medication? Well, this is where Pandora's box is wide open these days. And it seems like every day a new agent is coming out. And so it's really hard to even keep track of them sometimes. But there are several classes, I guess I would say, of these treatments. One is chemotherapy. So what's chemotherapy? That's cytotoxic therapy. The idea there in general is to kill rapidly dividing cells. So if you think of cancer cells as being rapidly dividing, then it would kill those. And the chemotherapy agents of decades ago are not the chemotherapy agents of today. in terms of side effects and safety. So a lot of women don't really get so sick anymore. They can work during chemo depending on, what their job is and so forth. But they still lose their hair because that's also a rapidly dividing cell. And fingernails are a problem because those are rapidly dividing cells. But generally speaking, it's not as bad as it used to be. And there are a myriad of chemotherapy agents. So if somebody looks like they're going to benefit from chemotherapy, the medical oncologist will meet with them, review all of their information and say, okay, for your type of cancer, these are the chemotherapy agents we should give in this combination, in this sequence for this many treatments. So it gets very personalized, which is good, and also very complex to figure out exactly which regimen patients will need to take. Beyond chemotherapy, there's something called HER2-based therapy. So Herceptin was the first of these drugs that specifically target the HER2 receptor. And that's a specific type of breast cancer that's an aggressive subtype. But because a genius scientist discovered this receptor and this medication that could target it, these women that have this subtype of cancer are just doing great. And the Herceptin is now accompanied by a number of different other HER2 agents that are being used in combination with it or alone. So that's just a great thing. And when I first started in practice in 1998, Herceptin was just, coming on the scene, and it was only used in people with metastatic disease who had stage 4 cancer and were probably going to die. So they were trying it. Now we'll give it to somebody with stage 1 HER2 positive cancer. So it's just gone the whole gamut. We use it all the time. So another arm or sort of type of medical treatment would be anti-estrogen therapy, or we call this hormone therapy. So the majority of women will have estrogen receptor positive breast cancer, meaning that estrogen potentially could stimulate cancer cells to grow. And there could be a stray, or we say rogue, cancer cell floating around somewhere. And if they take medication that blocks estrogen, then theoretically it's going to keep that cancer cell from setting up shop and coming back, what we call a recurrence someday. So these would be medications like tamoxifen or Avista or Arimidex, which is an aromatase inhibitor. And their job is basically to block estrogen. So the side effects tend to be feeling like you're going through menopause and things like that. These are actually pills. So they're taken once a day, and they're taken usually for at least 5 years. So it just becomes a maintenance medication. The two up above are given IV, mostly chemo and HER2-based therapy. So they're more like IV treatments. Having said that, there's oral versions of these coming out, even the chemotherapy and the HER2-based therapy. So once again, what was always IV and what was always oral has changed quite a bit. And then there's a whole host of other targeted therapies being discovered all the time: PARP inhibitors, immunologics against very, very specific enzymes and pathways that have to do with breast cancer development, I should say. Let me just go back to that. So, well, I'll come back to that. The medical oncologists will also use something called genomic testing many times. And this is a genetic signature on the tumor to figure out what the best treatment is. So these are a few brand names of the different tests used, but basically most of these tests are designed to answer the question, will this person benefit from chemotherapy? And if so, how much? In other words, what do we predict is going to happen with this patient with and without chemotherapy? And then you can compare, okay, if you're highly likely to benefit from chemotherapy, then we should recommend it.
Did she freeze? I think you froze, Suzanne. Are you sending your chat?
She'll rejoin.
Sorry. Okay. I'm sure she's trying to sign back in again. She knows she's off, right?
It will get shut down. We can take this part out, but
Take what?
we can take this part out.
Of the recording. Okay.
Everyone just hangs tight.
Well, so far, it's been kind of interesting.
Maybe anyone has questions?
Does anyone have any questions so far? No. Well, it actually, she's explaining it in great terms for anybody to understand, which is really delightful. And not necessarily do you get all of this information in your doctor's visit. You know, I think that if you are diagnosed with breast cancer, it's a frightening thing the first time around to try to decipher all of this information and which choice is the right choice. And what to do. So we are also having another speaker tomorrow night, Mindy Goldman, who is also a general surgeon, OBGYN surgeon out in California, and she'll be speaking at 6 o'clock as well. You have to sign up for each link. Each presentation has its own link. So we hope you'll join us for next week, tomorrow. And then we also have 2 breast cancer survivors in a week on the 27th, I think it is, with Margaret Sear, and who's from the United States, and then Rita, who is someone that I just met recently, about 3 weeks ago, from South Sudan, who's been living here for many years. And they're both breast cancer survivors, stage 3 and stage 0, but then developed another type of cancer called radiation-induced angiosarcoma. So I think that the breast cancer survivor stories will be quite interesting next week from these 2
Oh,
women.
she's joining,
She's back?
except on the top, on the very top blue button.
Oh, admit. Here she comes.
That's her, not Suzanne.
Hi, Suzanne.
I'm back.
Yes, I'm going to share the screen again.
We're good.
We're good.
I just like totally lost my internet, I guess, or something. All right. So here we go. Sorry about that. Okay. So what I was saying is you watch all these commercials for all these medications and people are like riding bikes and playing with their dogs and going to dance recital. But actually it's true that there are so many of these amazing medications that they've discovered for all these little points in the pathway on not only breast cancer, but all sorts of cancer. Lung cancer is another one where they have discovered all these little tweaks they can do. But for right now, most of these drugs are in use in people with metastatic disease. It may not be that they had stage 4 disease, but they might have had cancer that was starting to spread into their lymph nodes, or it was refractory to treatment 1 or treatment 2. So now they're going on next, 3rd and 4th line treatments. But it's just amazing how this area is exploding. And so this is part of the individualization of treatment. If you have this type of tumor, this is your treatment. If you have that type, this is your treatment. And they can actually now do testing for certain types of pathways. Like there's something called a PIK3A mutation. So, that's one where, okay, if you have the PIK3A mutation, this medication could be used. But if you don't, then you can't use that medication. And I mean, it's just an incredible field. And so every time you watch one of those commercials, it's going to be another new medication that somebody's discovered that they're testing out. And I think just like when Herceptin came out, which was for metastatic disease, now a lot of these may move into more of the first line treatment as we get farther into it. So it's actually pretty exciting. I mean, from when I started my career, my training until now, there are just so many things we weren't doing then that we're doing now. One thing I wasn't even talking about was genetic testing. We hadn't even sequenced the human genome when I was in training, and now we do genetic testing on patients all the time. And it's just amazing to me that just in a couple of decades, we went from one end of the spectrum to the other end of the spectrum. And the same thing is happening with these medications. So even though the surgical techniques have gotten better, the radiation has changed a little bit, those two things are pretty much very similar to what they were. But the medical oncology field has just gotten so complex now with all these new discoveries. It's pretty amazing. So this is just to talk about survival, improving and improving and improving from just a few decades ago. I know it's a little bit blurry, but it was like in the 90s where we really started to see the improvement in survival. So just kind of summing all that up to say, I mean, obviously none of us wants to be the one to get breast cancer, but it's very, very common. 1 in 12 women are going to get breast cancer. And that means we all have to be, 1 in 8 women are going to get breast cancer, 12% lifetime risk. So if you know 7 other women, like you could be the one that gets breast cancer. And we're doing great with all these treatments, with survival. But what you want to do is if you're going to be the one to get breast cancer, you want to get it early. You want it to be found on a mammogram. You don't want to wait till it's a lump you can feel. And this is independent of family history. Most breast cancer actually occurs in people without family history. So please, please, please get your mammogram every year if you're over 40 until you got 1 foot in the grave. And I like this little saying I found online: cancer is not quarantine. Check your breasts. Cancer does not care that we're having a pandemic. It's still happening every day. I see women. So I just want to encourage you in that. Also, one more thing I wanted to mention is to dispel the myth that breast screening is expensive. Mammograms, I mean, they can be expensive, but programs exist in almost every state for coverage for free mammograms for people that can't afford them. So in Maine, we have the Maine Breast and Cervical Health Program, which also provides like pap smears and so forth. Like in North Carolina, where I used to practice, they had the BSEP program, which was the same thing, breast and cervical cancer screening. So that should not be a deterrent. And, even at Mercy Hospital, they have a charity care plan. So really the cost, I wouldn't want the cost to be something to keep somebody from going, because there are programs out there. So that's my whole presentation. Sorry, I went out for a few minutes there, but I'd like to know if anybody has any questions. Before I do that, I did want to talk about Bangladesh, but I didn't prepare slides for that. So we are so fortunate in this country because we have screening healthcare. I mean, in other countries, they're not so fortunate. They only go to the doctor when they're sick. And because of that, in a country like Bangladesh, they come in with these big, huge breast cancers that are untreated, that have been neglected and are advanced stage. And so that's not good. And so a lot of them do end up needing chemotherapy, but then chemotherapy is a cost they can't always afford. they definitely don't have these agents that I was just talking about. The Herceptin, I mean, they have it, they can't really afford it. All of those other agents that you see commercials for, they just don't have. They don't have that genomic testing I was talking about. They really don't have the genetic testing. So they're kind of left with very simple measures, the surgery, the radiation, and some basic chemotherapy, and maybe the hormone blockers. So they're kind of like where we were in our country back, I would say in the 70s, maybe. And so when you go there, you want to do all of these things, and then you find out, it's 50 years ago, which doesn't mean they can't get there. But me being a surgeon, when I go, I say, okay, let's try to at least make better surgical decisions, because they sort of feel like, yeah, we could do lumpectomies on people, but let's just do a mastectomy on everybody. We could do sentinel node biopsy on people, but let's just do a full axillary node dissection on everybody. So they have a little bit different mindset, that they don't want to ever bring anybody back for surgery. They don't, they have kind of the idea that more surgery is better, which we've learned in this country is not always the case, that survival can be just as good from a lumpectomy as a mastectomy. So when I'm going, I'm just trying to say, okay, you are limited because you don't have what we have, but you can still do less surgery and get the same results. And that's the message I'm always trying to get there. But of course, it doesn't always get through. But it has been good because I can teach them some of the surgical techniques, like just where I was saying, like the hidden scar surgery. I can say, okay, this is good. So we're going to do a lumpectomy. Let's do that with a scar in a better place, at least. Okay, we're going to do a mastectomy. I didn't really show this, but there are ways to do a mastectomy with a better scar. There are just a lot of things that you can do, in the way of teaching people. I mean, ideally, I'd like that country to get to a place where they were screening for breast cancer, they were catching it early, they were treating it the way we are. But again, we were there 50 years ago, and now we're here. So maybe 50 years from now, they're going to be where we are now. And I think they're making some progress, but their healthcare system is so much different than ours that they have a lot of work to do before they get there. But it's been great to go and work with the surgeons and share ideas and just teach them what's possible, because they don't always have the vision. They haven't been to the United States. They don't know what we do. They've only heard about it from people like me. And I think it would be great if they would come and see what we do, because they could learn a lot. But I'm trying to impart what I can when I go over there, and it's been really good. And I would say the surgeons there, they're fantastic. They're really good surgeons. The other members of the team, they're really good. They just don't have the resources. So, but they'll get there. The medical system there is basically cash pay. So, I mean, you got to have money to get treated, and that's the limitation. So.
Yeah, just to add to that, Suzanne, the National Institute for Cancer Research Hospital, where Suzanne and I have gone several times, they are government-funded facilities, so they do have the opportunity for surgery, chemo, and radiation. But as Suzanne said, they have to stay there because they travel by foot or by bus from hours and hours away. So they bring their family down, and the family is maybe the husband or maybe a child is living on the floor next to the bed, waiting for them to get their chemotherapy, which might be for 4 weeks or 6 weeks during that time period. So it's a real challenge, a real challenge for the people in many of these developing countries. There are also private hospitals where people can pay, who have the money, can go and receive treatment like they might receive here in the United States if they have the money to pay for it. Brings up that whole issue of is healthcare a right or is healthcare a privilege? When you have those kind of discussions. So Suzanne, could you also comment about radiation-induced angiosarcoma?
Yeah, so radiation is great. Obviously, it helps cure breast cancer. The goal being to sterilize the field where the cancer was, so any rogue cells don't grow. But there are some downsides. One simple downside is there is an increased chance of just skin cancer on that side. It's like getting too many sunburns. But then there's this other disease called radiation-induced angiosarcoma, which is one of the very rare side effects of getting radiation like that. And actually, I've seen a couple of people in my practice over the years with that. And you just have to kind of know what you're looking at. And it's like some things you don't realize it till you're looking at it and you're going, oh my gosh, I think this is an angiosarcoma. And then you have to do biopsies to figure it out. But it's it can be a very aggressive disease. It's a different kind of cancer, basically caused by the radiation. And the treatment is very aggressive to remove all of the disease, sometimes chemo, and you know, just a huge resection. Sometimes it could go into the ribs. Everything is removed with a mastectomy and more extensive surgery. But people can be cured from that. And so, you know, that's what you're hoping, obviously. But does that cover it? Is that what you were?
Well, what is one of the first signs of it? That, and it's when what people show up with something on their breast, right?
Yeah, so they show up, first of all, with pain. Now, breast pain by itself, we don't get too worried about. A lot of us have it, but this is a different kind of breast pain, and it's associated with a swelling in the breast and like this bluish purple, almost discoloration or little skin lesions that are almost like bruising that they get on the breast. It just doesn't look normal.
Right.
And it would be a change from before, because the breast after radiation sometimes doesn't look totally normal anyway, but this is definitely a change, like a bluish purple, bruised, painful, kind of swollen breast.
And something that is, I think the statistic of this radiation-induced angiosarcoma is like 1% of people that would end up with that. It's very rare, as she said. But one of the breast cancer survivors for next week that's going to share her story actually has radiation-induced angiosarcoma from stage 0 breast cancer, lumpectomy, treatment with radiation, and then 13 years later developed this. So interesting stories, because everybody's story is different and everybody's treatment options are different too. And then you have to take into consideration all the family and the support and everything else that goes into this. It's not just one single person going through breast cancer and treatment. It's how it affects everybody in the family and your whole life.
Right, it takes a village.
It's village, yeah. And I love that you have at Mercy the nurse navigator.
Yeah, we have, well, in our department in the breast center, 2 nurse navigators. So they help walk the patient through the surgical side of it and the post-surgical side. But then we have navigators in other departments too, like radiology, where they're getting the biopsy, genetics, and different areas.
One of the things that we did do on one of our first trips to the National Cancer Institute in Dhaka, Bangladesh, is we educated the nurses about doing self-breast exams. And then we actually went out into the slum, Koral slum in Dhaka, and there were over 100 women that showed up for our educational discussion about breast cancer, but also to teach them how to do self-breast exams. And we use this particular model that we make out of the prosthesis that come in and put 2 pebbles in the bottom here, and then we teach them how to do it on this model. And then we offered this group of women an exam, and we examined over 100 people, and there were 8 lumps. The 8 women that we found could feel definite lumps, some big, some kind of tiny, but something different. And then those people were followed up by the National Cancer Institute for mammograms, which was kind of interesting because these women never understood the word cancer, let alone understood that they could get it in a breast. So hopefully they're still doing their breast exams, self-breast exams, and then going out and spreading that information to other family members and other people in the community. Because if it's someone like that gets in Bangladesh that has 5 kids at home in the slum, comes down with stage 3 breast cancer and no opportunity to have appropriate treatment, she may die and then leave this family, all these little kids behind. So cancer affects the whole, everything, the whole big picture, not just, we have so many options here in this country, but so many people in other parts of our world don't. And so it's
Yeah.
teaching people how to do this is really important in the developing world and here.
And another facet of the exams is because they don't really have screening mammograms. I mean, they have mammograms, but it's just not a thing to go get a mammogram unless you feel a lump or have a problem. And so in India, they did a pilot study in these little poorer areas to just teach women, like nurses maybe, how to do breast exams. And then they would go to villages and examine other women. And because they didn't have mammograms there either, and they would find lumps, which then need to be evaluated, which might have been cancerous. And, if we could do one thing, I think if we could move in that direction beyond the self-exam, teach people to be examiners that could then examine women as well at clinics somehow. I mean, at least that's something versus nothing.
That's right. Any other questions or any thoughts? What, Suzanne, could you comment on breast cancer in men?
Yeah, so about 1% of breast cancers occur in men, so it's not unheard of at all. Sometimes in men, it's due to a genetic predisposition, and sometimes it's just out of the blue due to factors we don't understand, but men do have breast tissue, even if it's just a little bit of it. And I guess I would say women with tiny breasts can also get breast cancer. Sometimes they'll say, my breasts are too small. Actually, no matter how much tissue you have, you can get breast cancer. So in men though, it used to be said they always had to have a mastectomy, but nowadays we've learned they can also have a lumpectomy if they prefer, and then have radiation, and the treatments are very much the same as in women, and the survival's good for men. So really men should check themselves, although it's a little bit easier for them in most cases. I don't know if you want to get into this or not, but with all of the, let's say, transgender changes nowadays, this is becoming a little bit more of a problem for health screenings, because like say somebody born as a woman now wanting to be male still has breasts, but they're not wanting to get mammograms because they're now not identifying as a woman. Or somebody born male identifying as woman doesn't want to get, say, their prostate checked because the other reason. And so us in the healthcare world, we're having to be really vigilant about trying to get that message out to whatever your birth gender was, you still need the appropriate screenings for that. So just wanted to put that out there, that that's a emerging problem that we're dealing with.
That's interesting. And how to communicate that message without offending anybody. I'm sure it's very challenging. Yeah. That's right. What else? Any other thoughts?
I had a quick question.
Okay.
So for women with like a genetic predisposition for breast cancer, I saw that you referenced the BRCA mutation. Are there any options for risk reduction besides earlier screening?
Yeah, so women with genetic mutations of various ones might be candidate for what we call risk reduction surgery, which would be the most extreme. So like preventative mastectomy, for example. So if you have a BRCA mutation, your risk of breast cancer could be up to 90%. So basically you're going to get it. So then you can have risk reduction surgery with a preventative mastectomy, which we usually recommend by age 35, in addition to getting the ovaries out by age 35, because that's another associated cancer that's at risk. Beyond that, women with lesser risks or for some reason don't want to have that reduction surgery, they could go on something like tamoxifen, which is a risk reduction agent that they would take for 5 years. Tamoxifen has its own set of side effects, but that's another thing that could be done. I didn't really go into it, but there are a lot of, let's say, healthy lifestyle risk reduction things that can be done across the board, which helps reduce the chance of getting cancer and also improve survival if you've had cancer, like maintaining a healthy body mass index, eating a lean protein diet without a lot of processed foods, more vegetables and fruit, and then exercising 300 minutes a week. So, and reducing alcohol intake. So all of these things are also helpful with that. But that's not to say, okay, you've been diagnosed with cancer, just, eat salad every day, you'll be cured, because it's not like that. It's just to say, if you then get healthier with your lifestyle, you have a better chance at survival. So does that kind of all answer your question?
Yes, it does.
300 minutes a week?
Yeah. It used to be 150, but now it's up to 300.
I know, I thought it was 150.
Yeah, they just increased it. That's an hour a day for 5 days a week.
That's right. You
That's a
better
lot.
sign off and head home, everybody.
Yes, go get on your treadmill or take a walk or something, go to the gym.
Any other questions?
Actually, I have a question.
Sure.
What is the BRCA mutation? I'm not sure if I'm.
What is the BRCA
Oh,
gene?
okay.
mutation? Yeah.
Yeah. So genetic mutations, first of all, are abnormalities in the DNA that, well, sometimes they don't mean anything, but the ones we're talking about are what we call pathogenic. So they're known to predispose to disease. So in the breast cancer world, BRCA mutations were the first ones discovered that were identified that if you had this mutation in your DNA, you are much more likely to get breast cancer and ovarian cancer. And since those were discovered, now many more genes have been discovered, which we now test for dozens of genes every time we do genetic testing. And these genes aren't just for breast cancer. Some of them predispose to colon cancer or pancreatic cancer or uterine cancer, other types of cancer we consider hereditary. And so by checking for these, we can say, okay, you have this mutation. What cancer should we be looking out for in you? Or do we have to go to the more extreme, like, do you need a mastectomy or something? Does that kind of answer your question? There are other genetic tests for things like, say, Down syndrome. That's not what we're talking about. We're just talking about related to cancer risk.
So you would only be tested if you had a risk or you had been identified as maybe having a lump or something.
Yeah, so we usually test all of our newly diagnosed cancer patients, but we test a lot of other people with risk factors in their family. So like a family member with ovarian cancer, a family member with breast cancer before age 50, family members with pancreatic cancer, or a combination of different cancers in the family at different ages.
Because the likelihood would be that that genetic transfer
Right.
might be there. So if you
Right.
seen that, then it would be better to do it. And then the BRCA gene was one of the first genes found for breast cancer, but since then there have been other genes that they've identified for breast cancer.
Right, right. I would say the second most well-known now is called PALB2, which is breast cancer and pancreatic cancer risk. And then the one we find most often is called CHEK2. And then there are like Lynch syndrome. And anyway, there's a lot of other ones beyond that that we find. I was going to talk just for a minute about, you have your tests like 23andMe, for example. So that's not a medical grade genetic test that looks at a whole lot of things, but it does test for 3 of the known BRCA genes, which are what we call the 3 founder mutations. So breast cancer is very common in the Ashkenazi Jewish population, and it's usually one of 3 known mutations in the BRCA genes, and these are called the founder mutations. And so it used to be if we had an Ashkenazi person with breast cancer, we'd only test for those 3. Now we know you just test for everything. But the 23andMe only tests for those 3. So if you got a report that said, hey, you're not going to get breast cancer, you don't have the genes, that's not the full story. That's only for those 3 mutations. And if you're not Jewish, it really doesn't mean anything. But even if you are, it still doesn't really mean enough. It's not a good enough test to think you're off the hook. If you had risk factors, you would need the full regular medical grade test.
And then when you do have the gene testing and you find out, you can choose to change your lifestyle or be more perceptive about seeking treatment with earlier if you feel that something's wrong. Versus, but I think it must be frightening for some people to know that they have this predisposition to pancreatic cancer, for example, or something else.
Right. Yeah. Some people just, they don't want to know, or they think if they know, then they're going to get it. If I know I'm at risk for breast cancer, I'm going to get breast cancer. It doesn't exactly work that way, because if you're at risk, you're at risk. But I like to spin it as you can be more proactive. You know you're at risk, so let's be proactive. And yeah, if you think you feel a lump, we may have to check it out, and you're going to have more ultrasounds than the average person because of that. But then at least if it is something, we'll find it sooner, rather than just saying, oh, well, we don't know, we're at risk, and not worry about it. So, I mean, I always think it's a good idea, but not everybody wants to know.
Right. What other kinds of questions or thoughts? Okay, well, thank you very much for joining us. Suzanne, thank you very much. That was very, very informative. Very
Well, good. I'm glad. I'm glad.
Yeah, you have a great knack of explaining things in terms that everybody can understand. And that is really, really important in this day and age, that we get the full picture in words that we can understand. So thank you very much.
Well, you're welcome.
And thank
I
you.
appreciate you inviting me.
Yes. For
Right.
sure. And thank you to everybody else for joining us. And I hope that you'll be able to join us again tomorrow evening to hear Mindy. And we'll look forward to seeing you tomorrow night.
All right.
Thank you
Bye-bye.
very much.
Thank you. Good job.